Good afternoon, dear colleagues. My name is Adrienn Kovács. I'm a resident doctor at the Department of Internal Medicine and Hematology. And in the next minutes, I'm going to introduce a new type of diabetes mellitus, which is called the ketosis-prone type 2 diabetes. And this is the main focus of my PhD studies. So there is no doubt that during the ketotic phase of ketosis-prone type 2 diabetes, we must treat patients with insulin. But in the long term, maybe we can discontinue insulin. So my vision is that unnecessary insulin administration should be avoided in ketosis-prone type 2 diabetes. And that leads to my vision, which is to increase awareness about this new entity and to improve its management. I have two specific goals, two projects. First is a prevalence meta-analysis, and the second one will be a cohort analysis of Hungarian patients with ketosis-prone type 2 diabetes. Let me introduce my first project. So this ketosis-prone type 2 diabetes is defined by unprovoked ketosis onset. And despite the ketosis, these patients have normal insulin secretion, normal beta cell function, which is measured by the C-peptide level. And at the same time, they lack the autoimmune factors. The prevalence has been estimated to be between 20 to 50% in non-Caucasian ethnicity, such as African Americans and Hispanics, with the diagnosis of diabetic ketoacidosis. And in the table, you can see that this ketosis-prone type 2 diabetes belongs to the hybrid forms of diabetes according to the latest classification by the WHO in 2019. And this hybrid form group is now separate from the classical type 1 and type 2 groups. We also know that insulin can be discontinued in a significant proportion of these patients. On the other hand, we have very few data among Caucasian patients. But in our everyday practice, we do see that this is not a rarity. So our aim is with this first project is to assess the prevalence of ketosis-prone type 2 diabetes among patients with diabetic ketoacidosis at disease onset, and we would like to include the Caucasian ethnicity as well, and we will also assess the clinical characteristics. The prevalence question will be studied by using the COCO-POP frame, and the clinical characteristics will be studied by the PECO frame. Our hypothesis is that a significant number of patients won't need long-term insulin administration. And the clinical implication will be that the proper classification, which in this case means proper diagnosis of ketosis-prone diabetes, will contribute to the proper treatment. Systematic search was conducted using the 5 main databases. And here you can see the flow chart from almost 17,000 articles. After the duplication removal and the title and abstract selection, we now have 122 articles, and the full text selection is in progress. Let me move on to my second project. This is a cohort analysis of Hungarian patients with who was diagnosed with diabetes with ketosis onset. So in the literature, we see that the proportion of white patients with ketosis-prone type 2 diabetes is between 0 to 15%. It means, you can see in the table that in many studies they don't report patients with white ethnicity, but there was one study with 15% prevalence, and it actually meant 9 patients. In our center, we have data about 22 patients. So this will be a significantly higher number. Our aims with this second project is to describe the prevalence of type 2 diabetes among Caucasians presenting with ketosis at disease onset. And we would also like to compare this entity to the adult-onset immune-mediated type 1 and to the non-ketotic type 2 diabetes. Here you can see our study design. We had almost 200 patients. They had new diagnosis of diabetes. And based on the clinical features and the metabolic status, we separated them into 2 groups. And on the left side, you can see there was 90 patients with clinically type 1 diabetes. It means they had ketosis. And from them, based on the autoimmunity markers and the C-peptide function, we separated this ketosis-prone type 2 diabetes group. I would like to show some preliminary results. So this ketosis-prone group, which again means that they are autoimmune negative and they have preserved beta cell function. So this group, compared to the other 2 groups, they were older and more obese at the disease onset, and they had significantly higher HbA1c level and also the fatty liver index. This work is also in progress. We know that it is a limitation that this is a retrospective study and this is a one-center study, but as I mentioned, this would be the first cohort analysis of this entity in Hungarian patients. I would like to thank you for your attention with this quote, which is absence of evidence is not evidence of absence. And if you have any questions, then I'm happy to answer.
So if my understanding is correct, then this is a transient beta cell function deficiency?
Yes, exactly.
And would it be appropriate to look for pancreatic histology in this case? I'm not sure. So this is the first time I have heard about it. I'm just wondering why this transient failure of beta cells can occur.
There is debate on this, so we don't know the exact cause of this, but you were absolutely right. This is a transient loss of beta cell function. Maybe it is connected to alteration in the amino acid metabolism. And to answer your question, I think pancreas histology would be an invasive technique in this case, but maybe.
So our thoughts is that the disease is in the beta cells and not the receptors of insulin, right?
Sure.
Yeah.
It's a preserved beta cell function. The effect of insulin is transiently diminished. So both happens. Beta cell produces insulin, but not enough to the demand. And demand is higher due to the insufficient insulin action. So this is a more complicated story, and the correct answer that we don't know what the reason is.
Why didn't we know about this type of diabetes for so long? I mean, diabetes has been around for a while. And the other question is, do we have enough data to suggest any prevalence trends? Meaning that, is it getting more common? Is it getting less common? Is it just remaining a rare disease? Because I just want to understand, what is the impact of knowing it better?
So for the first question, I would say the classification has changed. So this type existed in the past as well. We just did not classify them as another group from type 1 and type 2. So basically they started their treatment with insulin because of the ketosis. They were most probably diagnosed as type 1 and they remained on insulin. So they were there, but they were misclassified, I would say. And for the second question, which was...
Is the prevalence changing?
Prevalence changing, yes. There is a connection to the obesity. So I would say that, I don't have exact data on that, but I would say that this is growing, yes, with the growing of obesity.